Our next speaker is Dr. Anita Banerjee, who's an obstetric physician in diabetes and endocrinology, and is going to talk to us about assessment and management of thyroid disease in pregnancy. Hi, Anita.
Thanks, Trudy. Hi, thanks, Trudy, and thank you, Carolyn, and everybody for inviting me to give this talk. Just give me a second for a minute while I sort my screen out. You've had a great talk by Melanie for hyperemesis and talked about gestational thyrotoxicosis. My remit was assessment and management of hypothyroidism in pregnancy. Okay. I just need to let you know that I do need to leave at 5 to 10. Got another meeting to go to, but I will whip through this in the next 15, 18 minutes and try and take as many questions as I can before I have to disappear. So thank you. So why is this important, and hypothyroidism and pregnancy? What I really want to do is ensure that today, after my 20-minute presentation, that you have a comprehensive understanding of the physiological and pathophysiological influences of hypothyroidism. You know what key information to ask from basic history taking, identifying red flags to ensure that we understand them and react to them and respond to them, and then apply the knowledge that you have gained in practice, and then more importantly, continue to share with other colleagues. So I just want to remind you about the physiology of pregnancy and the axis of pituitary thyroid, which is essential to make sure that we understand how to regulate thyroid and thyroid hormones normally. So you've got I hope you can see, because I can't see it here, but I hope you can see you've got the hypothalamus, which is releasing the TRH, you've got the pituitary gland, which is releasing the TSH, and then you've got your thyroid gland, which is releasing the T4 and the T3. Okay, so TRH needs to be released for the TSH. TSH then releases the T4 and T3, and then there is a negative regulation. So there's too much T4 hanging around, as Melanie showed. There are many reasons why there could be a suppressed TSH. And then what we've got then on top of this is the placenta and the baby and the hormonal changes that happen, particularly in the first trimester, when you've got a big rise in beta-8-CG, which then influences what the thyroid function tests look like. And we'll talk about that as we go forward. What are the changes in the thyroid?
Excuse me, Anita. Excuse me, sorry, it's Derry here. Your sound is extremely chopped. Is there anything you can do with your microphone?
Oh, okay. I could try and put my mic on. Sorry, I'm in an open room, and 1 second. Let me put this on.
Thank you.
And see
Thank you.
Changing.
Yeah, we can't hear you now, Anita. Could you unmute yourself?
All right. Now can you hear me? Is that better?
Yeah, that sound quality is much better. Thanks for that.
Thank you. Thank you. I'm in a big, large room, and apologies for the echo. So you've had a chance to look at this busy diagram, and let's start with the green, the olive green here. Okay. So you've got thyroid binding globulin increasing. Okay. You've got the TSH suppressing here, and you've got if I can see this right, yes. And then you've got the the beta-8-CG increasing and then falling again. So there's lots of these changes happening in the first trimester, which protects the baby and understands why this first trimester is so important about having enough TSH. If we think about it, at the beginning, you've got the changes occurring, and the baby is very much dependent on the mother's thyroxine and the mother's ability of seeing things to protect the baby. And then at about 12 weeks, 14 weeks, the baby starts making its own thyroid gland and hormones. And it's really by 18, 20 weeks that the baby is very efficient in making their own thyroxine and kind of surviving in this world. What's really important is that all of these influences include the fact that you've got to be iodine sufficient. And there are pockets in the world, if you think of the Derby goiter, where there was iodine deficiency in the big goiter, anywhere where there's deficiencies of these things, you're going to have problems as well. So there's lots of things happening at this time. Okay, so hypothyroidism in pregnancy is a bit like asthma. It's the most common conditions that you're going to see in pregnancy. And really, who does it belong to? And it belongs to the multi-professional group. Hypothyroidism, why is it happening, and what do we need to understand about it? So it is the most common thing, and the reason being is mostly primary. So it's either an autoimmune thyroiditis, i.e. taking a family history. It could be iatrogenic, i.e. because the goiter's been removed, because they've had radioactive iodine because of Graves' disease. There's a reason why they've got hypothyroidism. Obviously, you can be born with congenital hypothyroidism. And in this country, remember, you are checked for this from the day you're born when you have the heel prick test. Or there could be other reasons why you've got medical problems and you may have an abnormal thyroid, including amyloidosis, sarcoidosis, and many other things. So that's primary. You can have transient thyroiditis, and Melanie's talked about gestational thyrotoxicosis, which causes an overactive thyroid picture biochemically, but you can also get a hypothyroid postpartum thyroiditis or subacute thyroiditis when the TSH is raised and the T4 is down. And then obviously, as I showed earlier, that the pituitary gland is affected by the hypothalamic glands. Anything that's affecting that axis will also influence whether you have hypothyroidism. So what are the most common things, and what are we more concerned about? And I think it's important. I know we work across different sectors and our cutoffs may be not similar, and it is important to understand your own cutoffs for gestation-specific thyroid function tests. But what I would say to you is that pure hypothyroidism is when the thyroid TSH is greater than 10. Okay, the mother is symptomatic, and this does have effects on the baby, causing neurodevelopmental delay, high drops, preeclampsia, low birth weight, and influences pregnancy outcomes. Now, subclinical hypothyroidism is what we need to understand about. And for non-pregnancy and pregnancy, what does it mean? Do we need to worry about it? How do we reassure women that everything is going to be okay? There are many women that conceive with the TSH that's slightly raised, and the biggest concern, because of poor papers and poor data from 20 years ago, that the baby is going to have some issue with their neurodevelopmental and cognitive development and have problems later in life. But I want to reassure you that if you conceive with a TSH between 4.2 and 9.99, that's just not going to happen. So therefore, we say it's not significant. You should treat symptoms and understand where you're heading next. So how do we, with any condition, and particularly with hypothyroid disease in pregnancy, understand what we're doing? So timely diagnosis, and I hope by the end of the day, preparation for pregnancy and understanding you've got a condition is really important. So get the diagnosis early before they conceive. Treat as soon as you understand somebody's got a condition, particularly hypothyroidism, because it does influence fertility. Education and reassurance. There's a lot of education and reassurance and refreshing information to give to GPs and the wider community about hypothyroidism in pregnancy. And it's always a multidisciplinary approach. So when we think about endocrine conditions and we think about hypothyroidism, you've got a functional problem and you've got a structural problem. And it's deciding where is the issue, why is there an issue, and it's an art. Okay, so you may have a large goiter, but you may have a normal thyroid function test, and you may be asymptomatic. Okay, you may have a normal sized thyroid gland. However, your thyroid blood tests are abnormal, i.e. your TSH is raised and your T4 is low, and you're symptomatic, and you need to understand with endocrinology and with hypothyroidism how the patient feels, how are you treating them, and then what are you going to do next, when? And I hope in the next 10 minutes I'm going to go through that with you specifically. So first of all, we've got to screen for thyroid disease, and we need to understand. So this is kind of a list of things that you should be having in your head when you're seeing, well, could this woman have hypothyroid disease? Okay. So symptoms and signs of hypothyroid, we'll talk about that in a second. Is there a history of thyroid disease in the past? In her last pregnancy after this, did she have symptoms? Is there a story of infertility? Is there a history of recurrent miscarriage or preterm delivery? The presence of antibodies, I will come back to. What do the antibodies mean, and why was somebody measuring them? Any woman that has a polyautoimmune condition, i.e. type 1 diabetes, may have other polyglandular conditions, including an overactive or an underactive thyroid condition. Pituitary problems, has anybody had any operations on the pituitary? Is this why their thyroid function test is affected? We've talked about thyroid surgery, or unfortunately, as the women get older and present with having long-term medical conditions, have they had any neck irradiation or head irradiation for any reason in the past? And obviously, we've got our women who have in the past or could be on lithium during pregnancy for their perinatal mental health, or in the past may have used amiodarone for their heart condition pre-pregnancy, and has this influenced their thyroid function test that we're now seeing now in pregnancy? So how do we make a diagnosis in pregnancy, and what is our approach? So I think the important thing is, ideally, you should be measuring your thyroid function test at least 3 months before you conceive, but definitely measure it in the first trimester, and then in each trimester if everything is normal. And this is really important because there is a preference across some of the guidelines about this idea of increasing your as soon as you conceive, you should increase your thyroxine medication by 25 to 30% if you're going to have a good outcome. And this comes from that idea that you need to be so optimally managed with your TSH and T4 in the first trimester. I think this premise about increasing the thyroxine dose in the first trimester, this is not a good idea. Let's go back to basics. Let's do a blood test and decide if the woman needs medication rather than just giving it. And unfortunately, there's a lot of education and training to be done across our areas. The important thing is, if they've had something like Graves' disease, they may have had radioactive iodine, they may have had a thyroidectomy. So they may be coming to you as hypothyroid, but you've got to ask, why are they hypothyroid? You know, is it an autoimmune condition? Did they have surgery? Because if they had Graves' disease, they will have TSH receptor antibodies still in their body. If their antibodies are in their body, though the woman may not have an overactive thyroid, that TSH receptor can go across to the placenta and affect the baby. So it's really important that this group of women are managed by a maternal medicine clinic rather than in a routine midwifery or a endocrine clinic review, because it's important, if those women have a positive TSH receptor antibody, that they are reviewed, discuss about the risk of having a Graves' disease again. But more importantly, for the baby, they may develop a thyroid goiter and have features of an overactive thyroid, even though the mother may be hypothyroid. Now, as I've said, and I've reiterated, do not increase the dose of thyroxine until you've got your TSH and T4, and be guided by symptoms and the values. Aim for your trimester specific ranges. So in St. Thomas's, we have ranges that are trimester specific. They're actually from 300 women in Germany, because that's our assay that we use. But you've got to use what you've got in front of you, though it may not be specific to actually the women that we serve, to be honest, because nobody's actually done the overall trimester specific huge test about, is there a difference between, you know, if you're from Africa, if you're from the Middle East, is there any changes? I don't know of any data. Measure the T4 and TSH, and only if you've made changes do you need to measure it again every 4 to 6 weeks time. Otherwise, each trimester is enough. The important thing that we need to be reminding women, particularly as they get pregnant, is that they're on thyroxine. They should be having it on an empty stomach with some water. And more importantly, they should be not having their iron or calcium tablets, which you know we love to give to our women at the same time. This will, if we give the iron and the calcium tablets at the same time, you will actually not be able to absorb the thyroxine. And then you're wondering why you're increasing the dose, the values aren't right, and we're not getting anywhere. So I think we should all be aware aware of that going forward. And then T3 medication in pregnancy, I have not been trained on using it as an endocrinologist registrar, and then as a consultant. I've never used T3 in my practice. So if anybody comes to me saying that they're on T3, I would say, you know what, whoever's prescribed it should be managing it, and we would advocate to actually change to thyroxine or levothyroxine normal dose. So that, I think that's really important that we all say the same message. So the important thing about any medication in pregnancy and the postpartum period is that we advise them that it's safe. It is absolutely safe to take thyroxine, okay, and it will not influence anything. It's really important that the woman has another thyroid function test measured about 6 to 12 weeks postpartum because of the risk of postpartum thyroiditis, and ensure that they're not over-treated or under-treated. And that should really be in primary care. I would say in the past 20 years, primary care are fantastic at recognizing women with hypothyroidism and men, and can measure TSHs very quickly and actually titrate doses up and down very, very easily. So what do we do when you've got a history of a woman who's had thyroid surgery or radioactive iodine? I think it's important to understand what condition they've had, what is their pre-pregnancy thyroid function test, T4, TSH, where were they pre-pregnancy, and what are we trying to target during pregnancy? And it's really important to get that messaging across right from the beginning. Really, we should be doing it pre-pregnancy and during preparation, but during pregnancy, particularly women who've had papillary cancer in the past 10 years, we're aiming for the TSH to be suppressed, and we need to be working throughout pregnancy to ensure that we get this right and monitor them. So individualize the care specifically for these people. And again, I've talked about Graves' disease and checking these things. But if you're not curious, you're not asking why you've got an abnormal thyroid function test, why you're on thyroxine, you will never know that if the woman has had Graves' disease or has had papillary cancer in the past, which is the most common condition that you'll see. So what is the management of hypothyroidism if you see it in pregnancy? I'll be honest, I've only seen it twice in the past 20 years as a registrar and consultant. And this woman, unfortunately, had a baby that was not growing, it was not healthy at all. But if you've diagnosed it, the most important thing is you start giving thyroxine as soon as possible, okay? And normally we start with 50 to 100, depending on the weight, and then we adjust it accordingly every 4 weeks. So if you see somebody with overt hypothyroidism, you need to start it, and you need to start doses of 50 and 100. These are therapeutic doses is where we should be starting. Okay, I do not think we should be using thyroid antibodies in pregnancy. I don't think the TPO antibodies are helpful. I think the TSH receptor antibody for Graves' disease is very helpful, but there's a lot of data and research out there that have shown that the TPO antibodies don't really help us at this time. Okay, so postpartum thyroiditis usually recurs between 2 and 12 months postpartum, and it's really, really important that we review, see what the symptoms are, and then treat accordingly, and ensure that that the GP is aware of this and understands what to do. Now, there isn't any clear consensus about the duration of treatment, and I think you would really go by thyroid function tests, symptoms of hypothyroidism, and then titrate down as you need to. So here's a case of a 28-year-old lady who's 18 weeks pregnant, and she's got symptoms of tiredness, feeling cold. Her voice, her partner says, has just become a little hoarse. She's gained some weight and she's constipated. What do you think about that? So the issue is what's related to pregnancy and what's not. You've got to try and understand and tease out worried or not worried. And what I would say to you is that it's the symptoms of tiredness that is pregnancy related. So that's a difficult one. Is she anemic? Are there any other reasons? Okay. Weight gain you can increase in pregnancy as well. So again, you're going to have to understand, did things happen, and take that history about pre-pregnancy, were changes occurring? And again, constipation happens during pregnancy. So again, teasing those out. What you're going to get more information from is actually, are they feeling cold? You know, it's summer, it's warm, she's 18 weeks, everybody else is feeling hot, but she's actually feeling cold. So that's a really good marker. And the voice changes that she may have may also be a reason. Now, if she's got severe hypothyroidism, her baby will not be growing, but at 18 weeks, people may not have done anything. It may be her anomaly scan between 20 and 24 weeks. They pick up something, but as a midwife and as a nurse specialist, if you're seeing these women, you know, are they appropriate for their size and duration of pregnancy? And go and talk to the obstetricians and the midwives if you're not sure, is this pregnancy related or is it not pregnancy related? And then what about symptoms? And signs that you may see. So again, out of these, what is pregnancy related and what's not pregnancy related? And how do you decipher the ones that you think, okay, you know what, that's okay, but that's not okay? And really, dry, coarse skin, I'm not sure, you know, how dry, but if it's pre-pregnancy and constant, I would say that is more consistent with hypothyroidism. Puffiness, unfortunately, is pregnancy related. You don't really get your alopecia until after you've had the baby. So if you're losing hair during pregnancy, you've got to wonder what's been happening. Women are not bradycardic, i.e. their heart rate does not drop during pregnancy. If anything, it goes up by 10 to 20%. Peripheral edema may be there because of the drop in albumin, the oncotic pressures have changed, so there may be more puffiness in the hands or the ankles. So that's not quite, you're not quite going to get it from there. And carpal tunnel syndrome, again, because of that puffiness, etc., in pregnancy, you're going to have that symptom. But again, you need to ask: was these symptoms before pregnancy, or were the symptoms after pregnancy or during pregnancy? Because then you'll understand and decipher: is this ongoing? Another symptom that I haven't talked about is headache. So the best thing to do, if somebody's been diagnosed with hypothyroidism pre-pregnancy and comes to you and you're just not sure where you are with the values and what they're saying to you, remind them and ask them, you know what, how did you present when you first had hypothyroidism, when the GP picked it up? What was it? Was it a headache? Was it feeling tired? Is it that you feel the same now, or is it different? And that's a really good marker to better understand what that condition is. And women will remember, you know, on that day, those weeks, I was having real bad headaches. I was constipated, feeling tired, and I went to see my GP, and that's when they diagnosed me, or there was a family history of it. So really, what I've hopefully said to you in this short discussion and presentation is that hypothyroidism is common. A thorough assessment and symptoms were normal to pregnancy and pathological. It's about deciphering that, and you've got a great series of talks today to help you understand that. If the blood tests are abnormal, you've got to give effective treatment promptly, okay? So there's no point waiting until the next review. You get the tests, you'll get them now within 24 hours, if not 12 hours, and decide who's going to see them next and when they're going to start treatment or increase medication. And the management really needs to be collaborative and individualized, every single woman that we see. I'm going to stop there. Thank you.
Thanks, Anita. That was an excellent talk. We've got a couple of questions. What are the risks connected with taking too much thyroxine in pregnancy?
Yeah, really, really good question. So it's a bit like being overactive thyroid and thyrotoxic. It's about actually you are hormonally and functionally not right. Therefore, you're going to feel anxious, tired, palpitations, tachycardia. Your baby will be seeing this overactive symptoms of you, and more importantly, having a higher risk of having changes of overactive thyroid, i.e. baby not growing, growth restriction, etc. So we do not advocate being over replaced. Women feel lousy. So many times women come to our clinic having increased their dose by 30% as told by these guidelines. And then they're jittery. They're actually sitting there jittery with palpitations. So I would really advocate, see the patient, decide euthyroid symptoms, and then make a call.
Okay, thanks. And then just one more question. Sometimes we get results where the TSH is raised, but the T4 is either high normal or higher than normal. How is that managed?
Yeah, really, really good question. So if the TSH is raised, the TSH takes about 6 weeks to reset, depending on which way it's gone, up or down. Okay, so T4 is a really interesting thing. So if you've got somebody who is not taking their medication, then suddenly, you know, because they know they've got a hospital visit or an appointment, starts taking lots of thyroxine, that may be why. So you've got to review the patient. Okay, understand their adherence, and adherence is a really important thing. As a diabetologist, you know, 50% of the drugs I give nobody takes. So, and I think in pregnancy it's probably about the same. So really, you know, understand, is this somebody who takes it 5 days a week, and twice a week they don't? Is it that they just miss it once a month? And take that conversation and understand. Does that make sense? Because you should not have a raised TSH and a T4. The only reason you'll have it, and I've never seen one in my career, is a TSH oma. So you've got a pituitary oma and your thyrox, and there's a reason why. But you know what? That's so rare that I wouldn't even think about it personally.
Okay. That's brilliant. Thanks so much for your time, Anita. Really appreciate it.